Good evening, everyone. Welcome to the webinar entitled, Why Do I Have Thyroid Symptoms? My labs are normal. This is unfortunately a very, very common scenario. I see a lot of patients that have been told that their labs are normal, and yet they have symptoms. What I want to cover in today's webinar is a bit about how thyroid hormones affect us, how thyroid hormone is processed in the body, and the standard approach to thyroid hormone replacement, as well as an alternative approach to low thyroid function. So I just wanted to state up front that as a webinar presenter, I am not giving any one individual medical advice. It is obviously the right thing to do to see your healthcare professional and discuss your personal situation. The content of this webinar reflects my clinical experience, and this is how I manage my patients. So I'll ask everyone to please silence their cell phone so we can be focused. I'm going to go through a lot of information today, and if you follow along, I think you will gain an amazing amount of information. If you don't, and you're kind of tuning in and out, I think you will miss out on a lot. I'm going to start out with a simple question, a little poll. If you guys will answer this for me, just so I can get an idea of what you guys have been through. So you should have a little poll come up that requests yes or no. So I'm seeing about 50-50. So that suggests that there is indeed a fair number of us out there who have thyroid symptoms, but the testing comes back normal. I'm going to give you guys a little bit of background about me and how I came to be semi-obsessed with helping patients with thyroid problems. I always knew I wanted to become a doctor who studied day and night and graduated as valedictorian from high school, college, and medical school. But I almost didn't make it through residency because of a thyroid problem. An interesting thing happened to me during medical school. I was the dummy for everyone to locate the thyroid gland on it. You see, my thyroid was so prominent that they used me. This led to a series of doctor visits for me. But all the doctors would tell me was, your thyroid is borderline. After medical school, I got married and started training to be a surgeon at the Johns Hopkins Hospital. I would come home and be so exhausted that all I could do was sleep. So I thought, now my thyroid must surely be a problem, and I went to a doctor to have my new symptoms and still large thyroid checked. But again I was told, your thyroid is borderline. You're having a hard time with residency, because surgical residency is hard. You might want to consider another specialty that is less demanding. In that moment, I saw my dreams shattering. Fortunately, someone recommended I get a second opinion. I was put through a more extensive battery of testing, and it was determined that I had an autoimmune problem known as HASHIMOTO'S disease. So Synthroid was prescribed, and at first it seemed to help. But over a few months, the fatigue came back. To my good fortune, a professor of mine from medical school had recently developed a revolutionary new way of treating low thyroid function. Dr. McDaniel taught me how to optimize my thyroid hormone levels and thereby my energy. Suddenly, I was leading 5 a.m. surgical rounds and had energy left to spend quality time with my husband. This saved my marriage and my career. I'm grateful that I found help before it was too late. And I am most grateful for the privilege of helping others optimize their health. So let's start by reviewing a little bit about what the thyroid does. The thyroid has receptors on every single cell in our bodies. So that means the thyroid pretty much affects everything, okay? First and foremost, the brain is one of the big users of energy in the body. And when our brain doesn't get enough energy because there isn't enough thyroid hormone, we feel tired, fatigue, brain fog, huge symptoms with thyroid. Our metabolism slows because thyroid has a big role to play in setting our metabolism. Our fat burning enzymes don't work. So lots of things, gallbladder, liver, all of those slow down. We don't detoxify as well. Our gut doesn't move. We get chronic constipation. Our hair growth is impaired and we start losing hair. Lots and lots of symptoms. So the thyroid can give a whole host of symptoms that affect virtually every system of our body. So let's talk a little bit about how thyroid hormone is regulated. This all starts in the brain. There's an area in the brain called the hypothalamus, very important control center. It basically samples the blood for all the hormones and signal molecules that are running around and determines what is needed. This hypothalamus of the brain then sends a signal to our pituitary gland. And the pituitary gland, which is located at the roof of the nose, in fact, surgically, that gland is often approached through the nose. So it's kind of right at the base of the brain. This gland generates hormones. One of those hormones is TSH, or thyroid stimulating hormone. This hormone will stimulate the thyroid gland to produce thyroid hormones. So T4 and T3. Let's look at what exactly those thyroid hormones are. So the thyroid is going to produce 90% of what's called T4. Now, T4 is what is in the medication Synthroid and levothyroxine. So the majority of the output of the thyroid gland is T4. And I'll show you what these look like and why it's called T4 in a moment. About 9% of the hormone coming out is T3. Now, T3 is very similar in appearance and yet very different functionally from something called reverse T3. And our thyroid gland puts out a tiny bit of reverse T3. I'm going to ask the audience here, how many of you guys have heard of reverse T3? Usually I have a very educated audience for this, and oftentimes they are familiar with it. Yeah, so it looks like more have not heard about reverse T3, so I will make sure that I explain that quite well. Thank you guys for that feedback. Okay, so this T4 hormone is the one that's coming out most quantity-wise. The T3 hormone is what is coming out in smaller proportion and a tiny bit of RT3. So T4 is basically a precursor hormone, a pre-hormone, if you would. It has some activity, but T3 is the real active thyroid hormone, okay? So T3, we say, is about 5 times as active as T4. So T4 is a precursor. The active form of thyroid hormone is really T3. The reverse T3 is it's very similar, and I'll show you what the difference between T3 and reverse T3 is, but think of it this way. If T3 is if you're a car, T3 is going to be your accelerator. Reverse T3 is your brake. So T3 and reverse T3, and we'll get into this a little more, balance thyroid function. The thyroid gland puts out a precursor hormone and then a little bit of the active hormone, but most of the active hormone is generated in the body. Now, behind my picture, that arrow is pointing to T3. So 90% of the output is divided then into T3 and reverse T3. And we're going to talk about how and what that exactly means. So why does the thyroid gland release a pre-hormone or a precursor hormone instead of the active hormone, right? It releases a little active hormone, as we said, but mostly it puts out the precursor. Simple way to think about it is the same reasons that Campbell's soup puts soup in cans. Easy to transport, long shelf life, and you can open it when you need it. So you don't have to use it unless you need it. So same reason. And the thyroid does the exact same thing. And so next, let's talk a little bit about what happens. Here's what these things look like. You see those little eyes, the arrows pointing to one of them. The eye represents a molecule of iodine. You know that thyroid function is really dependent on iodine. If you're severely deficient of iodine, you get this big goiter while your thyroid gland enlarges, trying to scramble every bit of iodine it can. So iodine is required for thyroid function. As you can see, it's an important component of thyroid hormone. The top figure there is T4. The 4 comes from 4 iodine molecules. On the bottom, you see one of the iodine is missing. Okay, the bottom left where the arrow is on the top one. This makes it T3. So in order to activate T4 to T3, the body takes one of those iodines off. Okay, that's how that happens. Okay, the body can also take a different iodine out. It can take the iodine that's toward the inside, towards that side chain. You see the lightning symbol, right? If it takes that iodine, you end up with what's called reverse T3. So it's just a matter of which iodine molecule gets removed, and it makes all the difference in the world. As I said, T3 is your accelerator and reverse T3 is your brake. So depending on the body's choice, it can give you a brake or it can accelerate you. So the body in its wisdom is going to decide what it needs. The thyroid has just basically provided the raw material. So the reverse T3, and we're going to abbreviate it RT3 for short, blocks the effect of T3. And there is nothing controversial about this. I've given you a whole list of published medical references that support this assertion that T3 can be blocked by reverse T3. And yet, most of you have not heard about reverse T3. Most of your doctors have probably not heard about reverse T3. It was initially identified back in the 1970s, so it's not something new. It's been around 50 years, but in practice, we're still not incorporating that. So here is something that can take your active T3 hormone and block it. You think that might play a role in thyroid function? Absolutely. So what's critical for the body is a balance, okay? The processing of T4, that means whether the body chooses to turn it into T3 or reverse T3, is very, very tightly controlled, right? It's very, very critical. So the conversion of T4 to T3 or reverse T3 is going to determine thyroid hormone function. How functional is thyroid hormone in the body is going to depend on how much of it is T3 and how much of it is reverse T3. This is the main means that the body uses to control the degree of thyroid hormone action in the body. So the ratio here, T3 to reverse T3, is critical. It is the best indicator for thyroid hormone activity. And yet, you haven't heard about reverse T3. A lot of doctors don't look at reverse T3. They don't measure reverse T3. They do not take it into consideration, and yet it is critical for the body's control of thyroid hormone function. So if your reverse T3 is elevated, that is associated with bad outcome. This has been published in many studies. So a high reverse T3 is bad for us in general. Okay, we'll talk a little bit about what that represents. Reverse T3, now we can measure its level, but if we just look at the level, it's not all that sensitive as a test. What does that mean? That means it doesn't give you all the answers. It might miss some. Okay, so the better test to look at is actually look at a ratio between T3, the active thyroid hormone, your accelerator, and your brake. How fast your car goes is going to be determined by how much acceleration there is versus how much braking there is going on. So this ratio. So we want 10 times more, okay, T3 than reverse T3. Okay, that's where we want to be. So this ratio is a better indicator of thyroid hormone signaling than TSH. And yet TSH is what is used to measure thyroid function. You go to the doctor, you're worried about your thyroid. They test it for you. What did they test? They tested TSH. Sometimes they'll test a T4, but in general, they're testing a TSH. So they're not looking at T3. They're not looking at reverse T3. So are you starting to get the idea of why you might have symptoms and your labs are normal? It's because of what labs are looked at. Okay. We're missing some of the critical labs. Okay. Now, our labs can report reverse T3, but they measure it as what we call a total level. T3, our laboratories are very sophisticated and they can measure it as a total hormone as well as a free hormone. What does that mean? Total hormone is the amount of hormone in the blood floating freely and the amount tied to proteins. The body also controls hormone function by tying it to proteins. The free is active. With reverse T3, the labs are unable to measure a free reverse T3. So we want to compare apples to apples. That means we want to compare the total T3 number to the reverse T3 number, not the free T3 number. Okay, that will not help us. It totally is really not related. So we have to look at the total and the reverse. So you'll start seeing where I write T3, and that's indicating total T3. Okay, so now we understand. So for lab measurement, it becomes important not to just look at T3 and reverse T3, but to look at, is it free T3 or total T3? Okay, so when we are looking at thyroid function, the optimal ratio is what we're going for. Okay, remember that the thyroid exit ratio is about 10 to 1, 10 T4 versus 1 of the T3, right? So 90% T4, 9% T3, 10 to 1 ratio. Greater than a 10 ratio indicates that your body's doing a good job activating that T4 into T3. If that ratio is low, then your body's kind of deactivating, right? You're braking instead of accelerating. So in healthy people, the total T3 to the reverse T3 value, the range is between 11 and 12. Pretty tight, right? That's not a big variation in the range. I find that my patients do well when their ratio is above 10, so 10 to 14. So in that total T3 to reverse T3 ratio, patients feel well. But if you have a patient not feeling well and you don't check this ratio, you don't pick up the problem. That's the key. And that's why so many people are not diagnosed. All right. Let's look at, here's here's actually a report on one of my patients. If you look at this, it's showing you TSH, free T4, free T3, total T3, and reverse T3. So these 5 are kind of my thyroid hormone panel. Now, obviously, I check other things as well, like antibodies, more on that later. But I look at these 5, and then I take the total T3, and I divide it by the reverse T3. It gives me a ratio. In this case, 124 divided by 11. So that's the ratio is 11.3. So this patient has a good ratio. Okay. And thyroid is not her problem. So she's doing good from that standpoint. Okay. So the blood tests for thyroid hormone are accurate. They're reflective of thyroid function. Okay. The T4 levels, they validate if the TSH is right or wrong. There are circumstances where these lab tests are erroneous because of something else going on in the body. The T3 and the reverse T3 are critical for telling us how the body's processing that T4, okay? The other thing we want to keep in mind when we're looking at labs is activity of these levels, not the activity, but the number of what the value is within that range. The TSH range, in the past, I remember years ago, up to 10 was considered normal. They've started bringing that range down a little bit, but really for optimal thyroid function, you have to be in a tighter range. Okay, so we look at optimal or functional lab ranges, not just looking at the range as given by the lab. Okay, busy slide here, but what I want to tell you is there are a lot of things that impact the body's production of T3 and reverse T3 from T4. Okay, so some things block it. Okay, and that's going to be things like toxins, things like being ill, infection, things of that nature, autoimmune diseases, right? Things that stimulate it are going to be vitamins, right? Certain minerals, okay? Presence of selenium is important for making T3. For making reverse T3, you actually don't need selenium. So people with a selenium deficiency will have problem activating the thyroid hormone. Everything, including down to exercise, is important for thyroid function. So we're not just looking at a TSH. So you can tell, looking at a TSH, TSH is not even on this diagram. It is so critical that we take all these other factors into consideration. So we got to get to the underlying cause. Why do you have hypothyroidism? Okay. Is it because the thyroid is out to lunch because maybe you weren't born with a thyroid, right? Is it because there's a nutritional deficiency? There's no iodine, or there is maybe no selenium? Is there a medication or a toxin that's affecting the thyroid? Is it because the pituitary is not working? Okay, so there's no TSH to stimulate the thyroid gland. Is it because the body's not activating the T4 to T3? Is it because the person is on oral contraceptives and that is making all of their thyroid hormones be tied to proteins so they can't work? Is it because of autoimmunity? So we're talking Graves and Hashimoto's. In this case, obviously, we're going to want to test antibodies. So figuring out the cause is important for optimizing the treatment. And again, conventional approach, they don't really get into that because they've got one treatment. If they decide to use it, it's going to be T4, levothyroxine, or Synthroid. But we're going to get into other options that are going to work a lot better. Okay. So let's talk a little bit about autoimmunity, okay? Autoimmune diseases basically mean that your own immune system is attacking a part of your body. In this case, the thyroid. And that is the most common autoimmune disease that there is. And the first one that was ever identified as an autoimmune disease was Hashimoto's thyroiditis. okay? 90% of thyroid symptoms among women in the US are attributable to autoimmune disease. So this is huge, by far the biggest cause, okay? So what's important to remember is that these autoimmune conditions, Hashimoto's and Graves', they're not just thyroid disease. They're a problem with your immune system. And we know that if you have one autoimmune condition, you're much more likely to have a second. So getting to the underlying cause of the autoimmunity, okay, whether that is exposure to toxic elements, exposure to too many chemicals, chronic infections, sometimes we never know, but optimizing lifestyle tends to help. Gluten in some patients can be an issue. So all of these things can have an effect on autoimmunity. I'm going to ask you guys another quick question here. So this is, if you have a thyroid problem, have you had your antibodies tested? So obviously, if you haven't had a thyroid problem, they're not going to test your antibodies. Yeah. Oh, it looks like I typed "ni" instead of "no." So some yes and some no. I'm getting about 50-50. Okay. So when my labs were tested, initially all they would do was a TSH. So majority is no. All they did was a TSH. And on that basis, they kept calling me borderline and putting me off. Subsequently, when I did get a second opinion, at that point, they did run my antibody levels and they were in the thousands. Okay. Normal's less than 9. And I think I was over 3,000. So my antibodies were just like crazy, insanely high. And so, I think it is useful. And it also tells me, and I know I have a family history of autoimmunity, I have to watch for these other conditions. So I think it's relevant, and we'll talk also about why it's even more important. Thank you, guys. Okay, so there are different antibodies, by the way, in terms of looking at Hashimoto's and Graves', and Graves' patients can have both of the antibodies we typically associate with Hashimoto's. So they can have some element of all 4. In Hashimoto's, there are 2 antibodies that we typically tend to see. And we'll talk a little bit more about the autoimmune issues later, because that is one of the challenging conditions for optimizing thyroid hormone function. So what do we want to think about before treatment? So we want to think about, well, how is the patient's overall health? How old are they? That's going to bear into what kind of treatment we want to consider. The nature of the thyroid problem. Are we looking at Hashimoto's? Are we looking at a nutrient deficiency? Are we looking at medications affecting conversion of thyroid hormone? Those things need to be figured out, okay? What are the other hormones doing? Okay, is the person on birth control pills? Have we started hormone replacement therapy? Okay, because if you make a change in the other hormones, it's going to impact. All of the hormone systems are interconnected. Adrenals are critical for this. People with chronic fatigue have a hard time with their thyroid function as well. So all of these things we want to take into consideration. What's our goal? Okay. Obviously want to feel like the gal on the right. Okay. Our thyroid wants to be happy. So optimal thyroid hormone effect is what we want. And we want to resolve symptoms and signs of hypothyroidism. We want good blood levels, and they serve as a guide, and they help us monitor therapy. Okay. So we want optimal numbers, and we want an optimal symptom effect. We want symptom relief. okay? In some patients, we want to actually suppress the TSH, go a little extra, and that's if we're trying to do that for patients who've had thyroid cancer or other issues. But in general, we're trying to optimize level, okay? If we use the right hormone dosage, we will not cause side effects. So the importance of the right dosage is critical. Okay, so what do the experts recommend? Well, they recommend Synthroid or generic levothyroxine, right? So this is at least a 50-year-old model, probably a little more, okay? So this is bioidentical T4. Remember, T4 is a pre-hormone. And the proponents of this treatment say that the T3 that the body needs, the body will take that T4 and make it. The critics of this approach are going to say, well, geez, can the body make T3? As we were talking about the can opener before, do you have a can opener to open the T4 and turn it into T3? That's the key. If you can't activate it, this is not going to work very well for you. I can tell you that. I went through that phase too. So the guidelines also suggest that treatment should be if the TSH is over 10, okay? And again, now we're starting to bring that level down a little bit, okay? And if the T4 is low, okay? So those are the things that conventional treatment is looking at, okay? I'm gonna ask you guys another quick question here. Just lets me know where everyone is. So this one talks about those that are on treatment. Say, do you take thyroid medications but still don't feel right? And I presume many of you guys attending are in that scenario, and so you want to learn and understand more. So this is for those that are on thyroid medication but still not feeling well. So I got 100% still not feeling well. All right, nope, I got 50-50. Okay, so some of you guys, looks like you're getting a good balance of the thyroid hormones and things are working well. And the other half are not. All right, thank you. It's pretty straight 50-50. Okay, so let's start getting into the treatment then. So this is the standard treatment, right? Do so much. Again, remember, if you don't have the can opener, you can't open the T4 and turn it into T3. And if that's the case, taking more T4 is not going to help, okay? So we want to be cautious about proper dosing. Very important. Medications are much easier to be compliant with and take regularly than something you have to take multiple times. It was not based on any science. It was just based on what would sell. Okay. So, divided doses, are they better? Let me explain on that little diagram. You see a blue curve with a single peak. That's somebody getting one big dose in the morning, just like Synthroid or levothyroxine is prescribed. And then the other curve, the red, shows where the dose is divided. So you can tell that when the dose is divided, the gray zone, which is optimal, is where you are staying, okay? Whereas otherwise, a single high dose gives you a high level, and then you bottom out, okay? So one thing, right, even this Synthroid that you're taking, one way to make it work better is to divide the dose, okay? So when you give a 24-hour worth of dose all at once, okay, the body's flooded and it's like, oh my God, too much thyroid hormone, hyperthyroidism react, right? Save me. So what does the body do? It makes more reverse T3, not T3, because it doesn't want to become hyperthyroid, and it makes a reverse T3 to slow things down and calm things down. So when you get too much T4, all of a sudden, the body has a tendency to make more of this reverse T3. So you're not going to get as good benefit in terms of energy level and symptom relief. If we divide the dose, as we said, that may help. Okay. I want to talk a little bit about some of the challenging issues and those that are still having symptoms. may likely fall into one of these categories. If you don't have a thyroid, you are really sensitive to what comes in because your own gland is not contributing. All right. So those situations, either for if you had radioactive iodine for Graves' disease, or you had a thyroid removed for a tumor or a goiter, you're liable to be more sensitive to replacement. Pregnancy will, of course, change the need for thyroid hormone. So will women's hormones. So birth control pills and hormone replacement therapy. So it really changes up the thyroid. I find that if I start a woman on hormone replacement and they're already on thyroid medication, I have to increase the thyroid dose, not because things are not working as well, but because the steroid hormones, the hormone replacement, makes the thyroid hormone not available to be free and float and work. So that is important. The other big issue is autonomous thyroid function. We'll talk a little bit about what autonomous thyroid function is, and if it's unstable, the thyroid function just varies back and forth. Okay. We'll also talk about something called subclinical hypothyroidism and type 2 hypothyroidism. These are the people that are either called borderline in the case of subclinical, like I was, or type 2 hypothyroidism, and these are the people with no can openers. They can't activate their thyroid hormone. Okay, so let's talk a little bit more about that. Poor T3 to reverse T3 ratio. Okay, if a person has this, they're not going to do well on Synthroid or levothyroxine. Okay, I'll get into more detail on this. You can give them T4, but the energy level just does not come up. They might feel a little better than they did before it, but it just doesn't work well. And autonomous thyroid we'll get into as well, and that's where the thyroid gland basically has decided not to take any orders from the brain anymore. And the hypothalamus and pituitary don't have any input. The thyroid is doing its own thing. So that becomes very difficult to regulate. There has been many studies done. There have been many studies done looking at a comparison for T4 treatment versus a mixed T4, T3 treatment. And people definitely, in general, prefer the combination treatment. And so the T4 does not quite do as well by itself. Okay, let's talk a little bit about this. So in the case of people that can't convert their T4 into T3, it's like giving these hungry kids a can of food with no can opener. You've given them T4, you've given them a can of soup, but they can't open it and get to the soup, and they can't make their T3. Okay, so that obviously you're not doing those kids any good. In a healthy person, 80% of their T3 is made by their body, but in somebody whose thyroid isn't working or isn't there, all of their T3, 100% has to be made by their body. And so the other issue that arises is not everybody genetically has a good can opener. So they're not efficient at converting this on a genetic basis. Okay. So if those people are just given T4, they're not going to do as well either. Okay. Those are the people that are going to still have symptoms. Now, stress is rampant, right? This year has been especially stressful for all of us. Stress has a tendency to take T4 into more reverse T3 and less T3. So the stress response slows our metabolism. Anybody that is stressed, that is trying to lose weight, can tell you that. You can't lose weight. Your metabolism is just tanked. Okay? So emotional stress, physical stress, disease stress is going to affect this response. Okay? So students studying for exams are going to have more reverse T3. Okay? So reverse T3 is the body's natural response to stress. And sometimes that's a good thing. Let's say you're lost in the woods and you're starving. Do you really want a high metabolic rate so you can die faster? No. You want more reverse T3 so you can slow down your metabolism and so you don't starve as fast. Okay? So there is benefit to having that reverse T3. But the important thing is the body maintain a good balance. So there's other causes, as I say, to our broken can opener. So that means you can't activate your T4. Various medications, beta blockers are very commonly used heart medications that cause this problem, okay? Iron deficiency, inflammatory cytokines, as we call them, chemicals released by the body in inflammation, okay? Endotoxin in the case of infection, mycotoxin, which is mold toxins, okay? Metabolic syndrome, which is insulin resistance, prediabetes. All of these make it hard to activate your thyroid hormone. So let's talk other circumstances. Now, this is not just activation. This is what we call subclinical, okay? This is what I think I had, right, when I was not being diagnosed. Mild hypothyroidism. The TSH is not really very high, and the T4 is normal. Doctors are not really sure what to do with this because some studies show that there is a benefit, and other studies show that there's no benefit. So it's a bit of a toss-up. And so a lot of doctors would just say, hey, it's borderline. Let's just keep an eye on it. And that keeping an eye on it is we check you in 6 months. So let's talk about, aside from subclinical, what's called type 2 hypothyroidism. You've all heard about type 2 diabetes. Type 2 thyroidism, I'm sure most people have not heard about. Okay, so in type 2 hypothyroidism, this can lead to symptoms like chronic fatigue. Okay, but the TSH is normal and the T4 is normal, which means when you go to your doctor, you're going to come back with normal tests. So those of you suffering with normal tests may potentially have what's called type 2 hypothyroidism. And the hallmark of this is that ratio we talked about at the beginning, the T3 to reverse T3 is diminished. It's low. So you have more braking going on than you have acceleration. So functionally, you're going to feel like your thyroid is not working. And so if you have this issue, you are not going to get any benefit from Synthroid or levothyroxine because your T4 is already normal. You just can't activate it. So then it's just going to cause side effects for you. So what happens here in subclinical as well as in type 2 hypothyroidism is that you're not activating and it's not diagnosed because T3 is not looked at and reverse T3 is also ignored. So if they don't look at T3 and reverse T3, it will never be diagnosed. So question is, if we give people with T3 and reverse T3 issues a poor balance, and we give them T3, are we going to be able to get them to feel better? And the answer to that is absolutely yes. But if we give them just T4, it's not going to work. Okay? So this is why a lot of thyroid suffering continues. I've tried to indicate on my slides, you see those little tiny writing below the main larger font lines. Those are references, medical references. So what I'm saying is not just me, okay? It is scientifically validated, okay? So let's look at type 2 hypothyroidism. The way I like to kind of explain it, it's an activation problem. So here is your T3 trying to come out of the cocoon, T4, but it can't get out. So people might be diagnosed as having normal thyroid because their TSH and T4 are normal, but their ratio, T3 to RT3, is bad. And so they basically, their T3 is locked up. If the process is jammed, they can't get better. So with poor activation, euthyroid Hashimoto's, or, before Hashimoto's, when just the antibodies are positive and, or the gland is getting attacked, but you don't have high TSH yet and you don't have a low T4 yet, it will show poor activation. So instead of your car accelerating you around, you feel like you're pulling your car because there is no energy. So when you use T3, you bypass the block, okay? So when you bypass the block, voila, you're driving in your car again instead of pulling it. So I told you guys we would talk a little more about autonomous function, because with Hashimoto's and Graves, this is a big issue, okay? So we see this in Graves, we see this in what we call multinodular goiters, we see it in Hashitoxicosis, or Hashimoto's with a high degree of thyroid hormone. We see it in what's called a functioning adenoma. Okay, so in the Hashimoto's case, up to 10% of people with Hashimoto's will have a brief period where their thyroid, as it's getting attacked, thyroid stores a pool of thyroid hormone in what's called colloid. And when the gland is under attack, that colloid releases thyroid hormone too much. And all of a sudden you're hyperthyroid. But that doesn't last long. When that wears out in a couple of months, the gland is no longer able to produce a normal amount. So then you get the hypothyroidism, okay? So in the case of, Graves' disease, what's happening here is you have an antibody that's not just attacking and destroying your thyroid gland as in Hashimoto's, but it can actually act like TSH and stimulate the gland to overproduce, okay? So in Graves', as well as you have a nodule in the gland that is functioning by itself. Basically what it does, it's like that the thyroid gland is basically booting the hypothalamus and the pituitary and says, I don't need you, I do what I want. And as it does that, then the thyroid function becomes very difficult to control from a medical standpoint. It's at the whim of what are the antibody levels doing. And then you're trying to kind of, okay, what's affecting the antibody levels? You have to get to a much deeper level. Patients like this generally are not well served. So the patients that don't benefit from T4, they need T3, okay? So if you give them a combination of T4 and T3, it works much better than T4 by itself, okay? So definitely improves results for some patients. Now, even the experts, okay, local and international, agree with that. For some patients, it's beneficial, but it's still a rare patient that automatically is given that if they're suffering. Usually they're still labs are normal, an antidepressant is sometimes offered, things like that. So combination therapy, also long-time treatment with it, is proven to be safe, okay? So let's talk a little more about testing for thyroid hormone. So optimal levels, okay? This is kind of what I look for. I'm looking for a ratio T3 to reverse T3. Remember, total T3 to reverse T3 of 10 to 14. The free T, the TSH level by itself, if you look on the diagram on the left, you see TSH. We want it to be a little bit towards the lower side of the normal range. The T4, we also want it to be to the lower side of the normal range. Remember, T4 is what gets converted into T3. If you have a lot of T4, you're liable to make a lot of T3 and reverse T3, both. So we want the free T3 to be in the higher side. We want the total T3 to be in the higher side of the range, towards the right, as you see where those little arrows are, the yellow arrows. The reverse T3, we want that to be towards the lower side. So each of these hormones, we're looking for them and looking at them very precisely, okay? And then also, when do you draw your blood? Oftentimes, thyroid patients are managed. They're not really told when to have the blood drawn here. They're given that order. So very carefully, I want to know when the dose was, so I can determine where the patient is in terms of how far after their dose. So I will ask them usually to do it midway between their two doses, because I usually dose thyroid hormone twice a day. Okay, so very specific orders for how we want to test precisely. Okay. So when we replace T4 with T3 and we improve that ratio, so what we want to do is keep things in balance, right? So as we decrease the T3, we're going to be improving that ratio. So when T4 comes down, the T3 and reverse T3 ratio goes up. And that's what we want, okay? So T3 is not around very long. That's why I divide the dose. The dose peaks at a couple of hours, but it bottoms out at 12. okay? You don't really want up, down, up, down. You want more steady hormone levels, okay? And so dosing it twice a day, as I showed you in that initial diagram, is important, okay? So because T3 is more potent, okay, more powerful, if you would, than T4, it's also liable to give you more side effects, which is probably another reason most doctors are not really comfortable with it. They've not really used it and they're fearful of it. You have to be careful. Caffeine at first, when you start T3, is liable to be more noticeably an issue for you. Anxiety, jitters can occur. They never occur if we do this properly. If we gradually titrate the dose, we make sure that our patient is timing their coffee properly, okay? We make sure there's no issues with hypoglycemia. Low estrogen symptoms also can confuse these symptoms, okay? If you miss a dose because T3 is around for a shorter time period, you're going to more likely have problems. And if patients don't follow directions and they take the wrong dose, I had one patient one time did not bring down her T4 dose and added the T3. She got symptoms. So it's very important that you follow directions and it be handled very precisely. And if it's handled precisely, there's no worry. There's only good benefit, okay? So what are the alternatives to T4? Two major alternatives, Armour. We had other versions of Armour, but mostly they've gone off the market here recently, okay? And then liothyronine, which is T3. So T3 comes as a medication in a bottle. We have an option, okay? Armour, which is otherwise also known as desiccated thyroid or natural thyroid. And Armour is a combination of T4 and T3. The liothyronine is just T3. So if I want my patient to get a combination, I'll sometimes either use Armour, or if I want a custom combination, I will take some T4 or levothyroxine and use some T3, combine the two, and the patient takes one of each twice a day. And that is I think, the most accurate way of adjusting the dose. Okay. Armour has been around for a long time. So that was the first thing that came out. It was out way before Synthroid came out, okay? Experts have liked it, okay? Patients like it better than they like T4 in general, okay? And a lot of prescribers will prescribe it if they're looking to add some T3. But again, you have to be more cautious with Armour than you do with T4. Same concerns, and it is derived from pork. So if your patient is pork allergic, that is a problem, okay? So replacing T4 with Armour or T3, this is a process that should be done gradually, okay? Must transition slowly. So as we take the T4 down, we throw it off our scale, we add Armour, okay? Ultimately, we want to keep the patient in good balance at optimal levels, okay? So we know that roughly 100 micrograms of levothyroxine is equal to 60 milligrams of Armour, okay? And we know that that Armour has 38 micrograms of T4 and 9 micrograms of T3. So based on the math and the calculations, we can very precisely adjust a patient's dose, okay? So done carefully, there's no ill effect and no side effect. Patients tolerate this very well. So T3 helps when TSH and T4 are normal. Now, here's that type 2 hypothyroidism. Again, lots of published data. It helps in demyelinating diseases like multiple sclerosis. In ADHD, it's been shown to be beneficial in depression, okay? Definitely beneficial there, okay? Heart failure, beneficial there, okay? Low metabolism, beneficial there. You've got normal TSH and T4. Basically, you would be dismissed as having normal thyroid. Okay, so this has been complicated. I hope all of you guys got understanding and of why you can have normal blood tests and have horrible symptoms, okay? So kind of few takeaways. thyroid hormone is best divided every 12 hours, okay? That T4 even works better that way. So I tend to divide my patient's thyroid replacement in the morning when they wake up and an hour before dinner. That seems to work really well, okay? Therapeutic blood levels have to be checked precisely. And as I said, I do that full panel of 5 tests. And I do it at exactly so many hours after the morning dose, okay? The ratio, okay, is the most accurate way to look at it. And again, this is something that is not the standard of care. People do not look at this. It makes a huge difference night and day, okay? So some people will need T3 along with T4 to get their best clinical results. Now, there are people that can do fine with T4. I've had only one such patient in my practice, but again, I tend to see patients that are struggling and have not done well with standard thyroid replacement. So in addition, what I want to comment on is the entire body must be taken into consideration when we're dealing with a thyroid or other health issue for that matter. We've got to look at how are we feeding the body? Are we exercising it? Are we making sure our detoxification systems are working? What's our hormone balance? Where are we in terms of our emotional status, our stress level? All of those factors play into this. So when I work with a patient, I look at all of that. And that, I think, is what gives us our best outcome. Thank you, guys. Thank you for listening. I'm going to stay around for a few, and I'll take any questions. If you guys will please type those into the chat box, okay?